And we're back, and this is day one of World Healthcare Congress 2018. Thanks for joining us. And we're going to get a check-in with David Contorno, who is with Lake Norman Benefits, and he is based in Charlotte. Hi there, David. How are you doing?
Good afternoon. I'm well, thanks, baby.
Great to see you again.
Thank you.
And last year we had a check-in about employers and how it was really difficult to get employers to think outside the box, to change some of their benefit strategies, because it's harder to make changes.
Right.
What are you finding now?
There seems to be a shift occurring in the mindset of employers, and I think some of that's coming from the pain point is getting real high. I mean, the premiums continue to go up, although we've actually seen a quicker deterioration of benefits than we have an uptick in premium over the last few years. And so these out-of-pockets are going up. Number one cause of bankruptcy is medical bills, but a huge chunk of those people had health insurance and still file for bankruptcy because of medical bills. So I think the pain point is getting greater, and I believe both personally and professionally that people don't change until the pain of staying the same is greater than the pain of change. And I think we're starting to reach that tipping point in a lot of instances.
Okay, so they're on board.
Yes.
These employers are on board.
They're getting there.
What are they doing differently?
Well, first of all, and this analogy occurred to me while I've been here at this conference, most employers spend the bulk of their HR resources around benefits educating the employees on the benefits themselves. What they give almost no education on is how to properly interact with the healthcare system. And the analogy that I came up with is, imagine if when we're teaching our children to drive a car, we spent 90% of the time teaching them about the provisions of Geico instead of telling them how to safely and effectively operate the vehicle itself. That's backwards, right? So why do we do that in healthcare? We give almost no education around how to properly interact with the healthcare system, how to get high quality, low cost care, and how to be a good patient or consumer of that to ensure the best outcomes at the lowest price. And so there's a mindset in this country that we should be able to do whatever we want, whatever our doctor says, whenever we want. But the reality is doctors have the same bad days as we do, and they're no better off than we are. They may be getting divorced. They have bills to pay. And so they have ulterior motives that are clear and evident in all the data that we go through. And it's on the consumer, or in this case the patient, I think, to say, whoa, wait a second, I don't need that 70-inch TV. I'm fine with a 50-inch TV, okay? And so we've been very successful with employers in the small and mid-sized space at creating two doors into the healthcare system. Because if I created just my door, most employers would be very resistant to that because they feel that they shouldn't change their employees' behavior or tell them where to go. So we create two doors. One door says, do what you've always done and pay what you've always paid, because most of these plans are so bad we don't need to make them any worse. But then we create this other door, and this other door is generally going to be no cost to the employee. And let me give you a quick scenario. This is my own, and I have a video on this online. I had a hernia surgery a few months ago. In Charlotte, North Carolina, the price range was between $8,900 and $47,500. Now, I'm on a high-deductible family HSA. I have a $12,000 out-of-pocket before my plan picks up 100%. I take the least amount of insurance I can. I didn't go to any of those four places. Instead, I hopped on a plane to Oklahoma City. I went to Keith Smith's facility, Surgery Center of Oklahoma. His cash bundled price was $3,060. So I said to myself, wait a second. If I'm a self-insured employer, would I rather pay 80% of $47,000 and leave my employees owing $10,000 or $12,000? Or why wouldn't I pay 100% of $3,000? By the way, better outcomes at the $3,000 facility, better quality, lower infection rates, lower readmission rates. Why would I not pay for not only 100% of the care, but give them another $1,000 to travel out there, stay at a hotel for a night or two? Now I've only paid $4,000 instead of $35,000 as the employer, and my employee's gotten better care at zero out-of-pocket cost. Those types of discrepancies and opportunities present themselves throughout the entire healthcare spectrum, on medications, on primary care, on specialist visits, and certainly on surgery. And so when we get them to places where better outcomes are more likely, the cost also goes down. Those two things are inversely related in healthcare. And we can create a plan that creates no out-of-pocket for their employees and lowers employer costs, which also lowers what comes out of employees' paychecks.
Well, it certainly makes sense to me. Does it make sense to the employers?
I think inherently it does. The problem is that we often need to get a lot of the well-known players out of the way because when you reduce healthcare spend, then those traditional players also have to then reduce their premium. And when they reduce their premium, they reduce profit. A lot of employers are under the false impression that the traditional carriers are aligned with them because they think that a carrier makes more profit if they keep costs down. And that has not only never been true, but a provision of the Affordable Care Act cemented that in federal law, and it's called the medical loss ratio provision. So they need to understand that just like every other business that they interact with, those businesses are in business for one purpose and one purpose only, to make a profit. That's fine. That's my employer's client's job too. The difference is that my employer holds everyone else accountable for reasonable and fair pricing and services and structure, and they for some reason put a blinder on when it comes to that, what is for most companies second, third, fourth biggest spend, which is the healthcare. Okay. So this is taking that control back and saying, it's not appropriate for you, Mr. Carrier or TPA, to give me some high-level data. I want to know where the money's going, why it's going there, and most importantly, what I could do to lower that cost and to improve the outcomes for my employees.
What are the other questions that you're hoping to address at this conference, or messages that you're leaving with people you meet here?
So it really depends on who I'm talking to. I mean, this conference is so grand. There's so many opportunities to learn and teach and interact. So it really depends on who my audience is. But I think if there was one thing that I think our industry does a poor job of, and certainly outside of the industry, I think it's pretty commonplace, is that we intermingle the words healthcare and health insurance. In our brains, those are one and the same. And so when I talk about getting rid of someone's identifiable health plan, they interpret that as me getting rid of them being able to go see their doctor. And that couldn't be further from the truth. I mean, we are just changing who or how we're paying for that doctor. We are not changing the doctor itself. And the way that I try and illustrate this is I'll go into a meeting of employees, maybe when I'm getting ready to announce some what might seem radical changes, and I'll ask them, let me ask you guys a question. Who's your healthcare provider today? And everyone raises their hand and says Blue Cross or United or Cigna. And I said, guys, those don't provide any health care at all. None. Zero. They are your health insurance carrier. Your healthcare provider is your doctor, your pharmacist. What you just did would be like if I asked you what kind of car you drove and you said Geico.
Yeah.
Okay, so if we start to break those two things apart, and then there's one other step to that, and this starts to change everything. We need to put healthcare first. What does the average American do when they need a dermatologist, right? They have a skin rash, they have no relationship with a dermatologist. They go to their carrier directory. Right now it's online. Back in my day, it used to be in a book. They go to their carrier directory, they say dermatologist, they type in their zip code, and it shows them 25. And they pick down to 1 based on gender or ethnicity or next to my dry cleaners. None of those are quality-based metrics, obviously. And then they go. Imagine if we did the same when we were buying a house. Imagine if we called up Nationwide and we said, hey, Nationwide, I'm getting ready to buy a house. Can you tell me what kind of house I can buy, who I can buy it from, what color it is, what kind of features and options it have? No. We buy the house first, then we buy the insurance on it, right? Then we figure out how to pay for it. Same thing needs to occur in healthcare. We need to start to say, we need to empower the patient and the employer, because really together they make a consumer, because the employer is the payer, and the patient is the consumer of the services. So we need to bring them together in a unified way that says we need to collectively find the highest quality, lowest cost facility. And with sometimes a 10, 50, even 100 times delta in price, with almost always the higher quality facilities being at the lower end of the price spectrum, you're actually not only doing a disservice to every other plan participant by allowing your employees to go to those $47,000 places for hernias, but I would argue that you're harming every single participant on the plan by allowing that one person to go, because you're forcing everyone's rates to go up and everyone's benefits to go down.
Right. It definitely sounds like you have your finger on the pulse, David. And
trying to. It's whack-a-mole, because every time I push something down over here, it pops up over here. But it's a constant evolution, and this is a long-term journey. It's a strategic plan. Do you plan on having a company in 5 years, Mr. Employer? Do you plan on having employees in 5 or 10 years? Generally, they say yes. Well, why are we looking at insurance on these one-year increments? We need to look broader and more strategic.
All right, David Contorno, thank you so much for
Thanks,
stopping
Mabel.
by. Appreciate it. And I'm Mabel Jong. Thank you so much for watching. Stay tuned. We have many more interviews to come.